Okay, so this video is about cervical ripening, which is getting the cervix ready to dilate, which is a precursor to cervical change or dilation. And then we're going to talk a little bit about induction of labor and somewhat about augmentation of labor. And let me just move this so I can forward. Okay. Indications for cervical ripening and induction. Maternal and fetal conditions that warrant delivery. For example, hypertension or gestational diabetes or preeclampsia, cholestasis of pregnancy, which is sometimes associated with stillbirth. It's not part of your content, so I wouldn't worry about it. Prolonged rupture of membranes or preterm rupture of membranes if we sense that mom needs to be delivered. So that would be an indication to try and get labor started. Or if we have non-reassuring fetal indications like intrauterine growth restriction, oligohydramnios, which is again a low amount of amniotic fluid, which tells us the baby's not putting out urine, which means baby's probably not getting good blood flow through the placenta. Or if we have an intrauterine fetal demise and we don't want mom to have to stay pregnant any longer. Now, when can we not try to get labor started? If the patient refuses an induction, you cannot start one. Placenta previa, you cannot deliver a baby through a placenta without causing massive hemorrhage and blood loss. If mom has an active herpes simplex virus outbreak, there's a chance of vertical transmission to the baby, so we would not want to do an induction of labor at that time. Malpresentation if the baby is breech or transverse. The big risk with breech babies is that they can get head entrapment because the head is the biggest part, so the rest of the body could come through a cervix that's not completely dilated, and then the head gets stuck. So if it's a malpresentation, we generally don't. Prolapsed cord. If the cord is presenting first, we're not going to try and induce labor. We're going to get that patient delivered much faster. And you'll learn more about prolapsed cord in the next video series about labor at risk. If mom has had a previous cesarean section with a vertical uterine incision, she's at great risk for uterine rupture with an induction of labor. If she has a history of uterine rupture, that scar tissue is going to be weak and not tolerate contractions. That patient should deliver by cesarean. And if mom has actually had more than has had 3 C-sections or more, we will not induce labor. We will do a repeat cesarean. So agents that we can use, we have dinoprostone. This comes as this little shoestring suppository. That's Cervidil. And it's impregnated with a chemical called, or a hormone called dinoprostone. It's a prostaglandin. It helps soften the cervix, and it helps the cervix thin out a little bit. Prepidil is another form of that. It's a gel, and it would be inserted. Cervidil is the most common. There is some talk about returning to Prepidil use, but the dwell time for Prepidil is 12 hours. Unless labor starts earlier or we see some reason that we need to pull it, like if we hyperstimulate uterine contractions or if the baby's not tolerating some contractions. Dinoprostone doesn't really stimulate contractions in most people. It's supposed to soften the cervix. But sometimes when the cervix gets soft, mom's pituitary gland will secrete oxytocin, which makes her contract. The second medication we can use is misoprostol. This is also a prostaglandin. Sorry, I had to breathe for a second. It goes under the brand name of Cytotec. It was actually a drug used for stomach ulcers. So this is an off-label use, but it has a lot of evidence, anecdotal, and then it's been studied in the literature. Dose is usually like 25 micrograms. It's really tiny. You see they come in 100 microgram tablets. So it's a really, really small dose. It does essentially the same thing as Cervidil and Prepidil, but it doesn't have this tail that you can pull. Okay, mechanical methods of ripening the cervix. We have amniotomy or artificial rupture of membranes, AROM for short. It allows the presenting part to be better applied to the cervix because it allows the fluid to escape. It also stimulates the release of endogenous prostaglandin, that hormone that helps soften and ripen the cervix. And it does make contractions more effective because there's more pressure on the cervix with each contraction. The risk of doing an amniotomy are that if you have prolonged rupture of membranes, you are risking an infection called chorioamnionitis. You risk also, if the baby's station is high and the baby's not engaged in the pelvis, the umbilical cord can slip past that presenting part, and then we have a condition called cord prolapse, which is life-threatening to baby. And then, obviously, if you have a placenta previa, doing an amniotomy would rupture that placenta and you would have an emergency on your hands. So it would be contraindicated for that reason. And we have one last method of cervical ripening, and it's called the balloon method, mechanical dilatation with a Foley bulb. You can actually use a regular Foley, you just don't connect the bag, and inflate that balloon. Or there's a special catheter, I have a picture of it here, and it's got two balloons. It's called a Cook's catheter. And you would insert it, and you would get that first balloon past the inner os of the cervix, that inside opening of the cervix, fill it with about 60 milliliters of sterile water or saline, and then you would fill the other balloon, which is the vaginal side, with another 60. It can work really well with traction. If you tape it to the mom's thigh, you tug it a little bit tight and attach it to the mom's thigh with some tape, or you can instruct mom to every once in a while give it a tug. So the cervix can't be completely closed to use this. So if mom's cervix is closed, they're probably going to go with one of those misoprostol or dinoprostone methods. But if it's even a fingertip, if it's enough to just get that tiny catheter through, you can use this method. So the nurse's responsibilities with this: we do not insert them, but we help fill the balloons. We educate the patient. We document the time of insertion, the time of removal, or in the best case scenario, the cervix dilates to a point where the balloons actually fall out, and then we would document that. Also, sometimes these are uncomfortable to get in, especially the Cook's catheters, because they're inserted with a stylet. So providing pain relief and support are important in this process. And we are going to talk about oxytocin. So once you've ripened the cervix, and the cervix is thinned out, maybe a little bit dilated, and it's ready to dilate under the force of contractions, this is when we would ordinarily start oxytocin or pitocin. You might hear nurses refer to it as PIT. Oxytocin is a hormone that naturally occurs in the body. It stimulates the uterus to contract. It's most effective if the cervix is already ripe. Otherwise, what you're going to get is you're putting a lot of pressure and you're causing some pain to the patient, but you're pounding against a really firm, hard surface, and so you're going to get minimal change in dilation. You start off very slowly. This is a high-risk medication. Moms vary in their response to it. Some people go into a good labor pattern on almost no PIT. Some people need to go up to a lot of PIT. And you titrate that to maternal and fetal response. You want to have 2 to 3 contractions every 2 to 3 minutes, and you want to have a baby who is tolerating those contractions. The risks to Pitocin is tachysystole, or hyperstimulation of uterine contractions, when you get 5 or more than 5 contractions in a 10-minute window, averaged over 30 minutes. Obviously, you have a risk of uterine rupture, especially in those patients who have had previous uterine surgery, like a cesarean section, and fetal hypoxia, because a contraction actually puts pressure on the vessels in the placenta and decreases blood flow temporarily. So fetuses are built for normal labor, but if you put them into a hyperstimulated pattern, or if they're compromised to begin with, they may not respond favorably. Safe administration of oxytocin involves continuous monitoring of both the fetal heart rate and the uterine activity. We have a checklist so that you have to make sure that all the conditions are right. I will show you that in class. And if complications arise, you need to turn it off and give SBAR to your provider. Okay, and we're going to stop there.